Let's get real. Let's get loud. On America Out Loud Talk News, this is a McCullough Report and Focal Point Substack. It's a great pleasure to welcome to the program Dr. Chris Robillard, who is a doctor. He's a doctor of chiropractic. He's also, really a man of so many different, interesting facets. He's joining us today from Indonesia and the wonderful, resort community of Bali. And we're going to talk today about a very important kind of framework of understanding. I would say that, and it's called the Mountain Protocol. Chris, welcome to the program.
Thank you ever so much for inviting me today, Peter. Thank you.
Well, listen, you look great. You're getting a lot of vitamin D. You certainly are more tan than when we had talked to the United Kingdom about a month ago. Why don't you start out by introducing yourself? Who are you? Who is this man of great intrigue? And tell us, your general orientation before we get into the topic.
Thank you ever so much, Peter. I think, look, my name's Chris Robillard. Obviously, I'm a chiropractor of some 30 years, and I guess I'm also a psychologist, and I also teach mindfulness-based interventions, which I've been doing over the past 15 to 20 years as well. And I guess for myself, I've had some sort of curiosity or questions with regards to my clinical practice that have started or appeared right from the off. And the first sort of clinical puzzle that I noticed in practice was two real clear patient patterns that I saw arising. There was two groups. There was those that used to come to me and had lots and lots of treatment, both with myself and with other clinicians and other people in general, and they showed little, if any, improvement in their symptoms. But what I also found on the flip side of that was that there was those patients that had almost minimal treatment. I mean, in some of the interactions with myself, I almost didn't really physically treat them, and they showed strong improvement. So for myself, the first question that really arose from that was the treatment alone cannot fully explain the recovery that I was seeing. And I guess the observation when I stopped and looked a little bit further was those that weren't improving seemed to have other challenges within their lives. There was obviously relationship issues, there was other psychological challenges, there was lots of complex problems that seemed to be playing a part in the way that their pain appeared and the way that it was expressed. And obviously, there seemed to be something about just the interaction of talking to me that obviously had some benefit in those that improved. So the link for myself, I guess, it had to be something within the mind. There's a psychological or a mental component to their pain or to their improvement, as it were. And from that original starting point. It coincided with a very dear friend of mine introducing me to a local Buddhist group where I was living in Brighton in the UK. And I guess I went along curious and interested at Buddhism as a whole, but more so at the techniques, I guess, that it employed and it utilized. And it was that idea of that intentional focusing of somebody's attention in a very specific way and with a certain attitudes that seemed to be a very good way for people to train their brain. And most certainly it seemed to have benefits in their life. But there was one very specific part that I guess I was very, very interested in, and it was the little Buddhist saying that pain is inevitable, but suffering is optional. And there's this discussion that, all of us will face illness, we'll all face infirmity, and most certainly we'll all experience death. That bit we cannot avoid. But the interesting bit is that there's a circle around it, which is our relationship to those things. It's often the narrative of I don't like it, I wish it wasn't like this, I wish it could change, why me, etc. And the Buddhists basically describe this or say that this is the fundamental source of our suffering. So
Hmm.
pain is inevitable, but suffering is optional. So it's something again, once again, about our relationship to our pain that is the curious thing. So with this observation of my clinical practice and my patients, and then this sort of growing philosophical interest, as it were, I thought I want to know a little bit more about this in a little bit more detail. So I marched off after already doing 5 years of studying. I decided, right, I need to do a psychology degree. So
Mhm.
I went off and trained and studied, and after again another 5 years, gained my psychology degree, and then went off for another further 2 years to train in mindfulness-based interventions at Bangor
Hmm.
University. And this blending of sort of the mind and the body most certainly started my career, I guess, as an integrative health guide. Um, and at the same time as this, I guess I was also starting to see this rise within medicine, most certainly within the psychological side of things, but most certainly in the physical realm as well, um, where there was this growing number of different diagnoses. And obviously, if you look at the DSM, the most recent, the recent version, I mean, the number of diagnosable mental conditions has suddenly exploded. I think it's gone up. Don't quote me on numbers, but I think we're up past 700 or so.
Hmm.
And I fully understood the purpose and the intention of diagnoses and the use of them. But what it did seem to be is that these diagnoses were starting to become people's identity. They
Mm.
were both becoming, um, yeah, they were becoming labels, but then they seemed to become restricted and defined by these labels. And my question really was were these new conditions, or in lots of ways, what were we doing? Were we actually diagnosing elements of what I would define as a sort of the human condition, as it were?
Well,
Um,
certainly, Chris, certainly I see that in medicine in the non-psychological areas, where the number of diagnoses are also increasing, and the subcategories of various, I'm internal medicine and cardiology. The subcategories are increasing, and with increasing complexity. So when I was a student, it was estimated that the medical database was doubling every 7 years. Now it could be doubling every 2 years, and probably before that every 1 year. Virtually every drug I use now was not even available when I was a student or a resident. And so the knowledge base is massively exploding. And one of the things in the written materials you provided struck me is this idea of patients kind of either labeling themselves or we label them as a disease. So it's a breast cancer patient or a cancer survivor or a stroke victim. And recently, my mom was in the hospital with a stroke. And I noticed when I went to her room, her name is not even on the door. There's all this concern about confidentiality, and so my name is an Irish name, so it was MCC at the beginning. And then when I went to the nursing station, the way they talk about patients is, well, 224 needs this, 226 said this, 230. So people are reduced to numbers in the hospital.
sure, for sure. And it's that, that observation that people become this label, this name, and it, is most certainly first and foremost dehumanizing as a patient, to be sort of reduced down to that in itself. But like I said, all of a sudden the words that we use in and around, all of a sudden people become their depression, they become their cancer, they become
Mm.
exactly what it is. And like I said, what I'm not doing is dismissing the benefit and the role of diagnosis. We need to diagnose
Mhm.
itself. But what I would say is that there is this danger of, or this lack of almost awareness and understanding how that can be problematic. If I just put it in inverted commas, it
Mhm.
might not be the best. And for me, it sort of leads quite nicely into sort of this next this underlying question that was has pervaded, I guess, my professional career, is that, is there a difference between healing and cure? You know, is it possible for somebody to be cured and then not to be healed? And vice
Mhm.
versa, is it possible to heal them and then not to be
Well, Chris,
cured?
what's the difference? How can we understand this?
Well, I think curing, I mean, curing is the eradication or the removal of a pathology or
Okay.
the eradication of something, as it were. But healing is something slightly more complex. It's, you know, it's around identity, it's around meaning, it's around dignity, it's around adaptation, you know, it's based within the culture that we live within, the family and the community that we live in. And so, especially, you know, within chronic and complex illness, where there may well not be a cure, you know, I see modern medicine failing to a degree. We sort of fall into this trap. You know, curing is about the what it is done, the what is the actual treatment itself, the what that is done. Healing is more about the way that it is done. It's the, you know, the introduction, you know, the we've all had introductions or interactions with medics that, yeah, it just leaves you feeling dissatisfied and feeling uncomfortable and not cared for and reduced to a name. And if we ask patients to,
Yeah, yeah. I was going
sorry.
to say you reminded me of a phrase that they taught us in medical school. They should. It was said that we cure very rarely. That we only help people sometimes, but we should care about them always. And it is true. I use my mom as an example. She's just had a stroke. She's not going to be cured of that stroke. That's the hard reality here. And I think that's very important for people to realize. Every so often we use the word cure,
Mm.
and I did the other day. I had a patient actually yesterday who had breast cancer, and I was going through the history, and she did have surgery on the breast cancer. I think in about 20 years ago, and then some additional oral chemotherapy. And essentially, we use the word cure. She goes, "Yeah, I had breast cancer and I'm cured of it." But that's pretty rare. In my field, the heart disease is essentially not cured. Strokes are not cured. Many, as you know, musculoskeletal problems are not. I mean, you can tell me, do people get cured of various forms of, back and musculoskeletal problems?
I mean, incredibly rarely. I mean, incredibly rarely. You know, it becomes more, you know, of course, you have the acute injuries, which people do
Mhm.
recover from. And we have acute medicine where, of course, people have a broken limb or an injury that they fully recover from. But, you know, very, very rarely is that the case. It's about learning to manage, navigate, and work with these things, and working with sort of professionals like ourselves to try and work out what it is that I can do and what it is that you know, they can do, as it were, to help themselves. Um, but you know, going back to that, again, thinking about your mother, is I always remember. I did a conference many years ago with a pediatric neurologist from Alder Hey Hospital, a really interesting guy called Andrew Curran. And the title of his talk was "All You Need Is Love." And we were addressing a group of teachers, and he said, "What I want you to do is," he said, "I want you to think back to your time at school." And he said, "What I want you to do is I want you to bring to mind that favorite teacher that you had." He said, "We all had one." And he said, now, with that teacher in mind, he said, what I want you to do is reflect upon what it is that you remember most about them. He said, is it the things that they taught you, or is it the way that they made you feel? And, there's a ripple around the room. And he said, exactly. He said, we all remember how that person made us feel. And it highlights for me, one of the features or one of the factors within healing and curing is that, you know, a good doctor, a good practitioner, you just feel heard, you feel held, you feel supported, you feel cared for. And whether you be, whether there be a cure or not, definitely, it helps you move along that journey towards healing. Does that make sense?
Yes, certainly it does. And to just understand this excision of a pathology, a surgical cure or a medical cure, it is rare. I mean, people need to understand this. I mean, I personally have high blood pressure. I have hypertension. I've had it since age 25. I've had it nearly 40 years. So I'm not cured of it, but I'm living with it. And I think uh, what a lot of people struggle with, and doctors struggle with it, or a lot of times doctors don't even address it, is this aspect of kind of living with something, this idea of being healed of it. I don't walk around with my identity as, a high blood pressure patient. I basically just took my medicines about an hour ago before I got on this interview. But it brings us to this idea that in your work, you spend a lot of time on the word
Mm.
agency. And so can you help us understand that? What does agency mean in this context?
Well, I think maybe it's easier to sort of see where there was a lack of agency. So this sort of professional and then this sort of philosophical pondering, as it were, that was early on in my career, I guess came to a real poignant and pertinent moment where I was diagnosed with stage 4 throat cancer 10 years ago.
Oh,
And
no.
s- and so, I was age 40, 43, 3 young children. And, my wife, my sort of life and my wife's life got flipped upside down, literally. And what I'd been obviously observing and thinking and reading about, as it were, came to that real personal point. And the interesting bit is stepping from that sort of that moment of being observing and then being part of that sort of system, as it were. And the reason I mention it is that lack of agency was the most prevalent part for me. It was as you mentioned earlier, I became, C is for cancer, not C is for Chris. I
Oh,
literally I became my diagnosis, in the multidisciplinary teams or meetings that I was part of. It literally felt like I was in this storm with, 10, 12 people all talking about me rather than with me or to me. It was
mhm,
no collaboration. There was no,
mhm.
when you say about agency, for me, it's about where is it that I have choice and I have an element of control. There was very, very little within that.
Wow.
Um,
Hey, Chris, let me ask you something else since, you had this problem. After the diagnosis of throat cancer was made, was there ever a day in your life where you did not think about it?
um, for for a long, if I'm honest,
Yeah.
no.
Well, the reason why I
Uh,
asked that is my brother-in-law has had metastatic lung cancer now for over a decade. And he's very highly functional, professor at a university, very accomplished. And he told me that. He goes, when you develop cancer, he said, I'm just telling you. He said, every day. There's not a day that goes by where it doesn't come into my mind that I have lung cancer. He's had it
For
for a
sure,
decade.
for sure. I mean, it, I would say it's the elephant in the room, but it's just that all pervasive, yeah, background sort of narrative, as it were. It's like
Don't you think,
almost.
but Chris, don't you think that's special for cancer? I mean, I mentioned high blood pressure. I can tell you there are many days that go by. I never think about my blood pressure. I never do.
Mm,
I think there's something about cancer. I mean, people call it the C word, right?
mm,
I mean, there's something about cancer. People, people feel as if they are a victim of cancer. And then when there is a cure, that they are a cancer survivor. We don't call somebody a victim of diabetes or a survivor of diabetes, or we don't call somebody a victim of back pain or a survivor of back pain. I think there's something about special about cancer, but you've had it, I haven't, so you can tell
yeah.
us.
Well, yeah. I mean, it's interesting because I've got yeah. I get really sensitive. Funny enough, if I'm honest about those wordings, exactly that, because I go victim. For me, it's. Yeah, I don't know quite why victim and survivor. That they're words that really are sort of like quite powerful for me.
Hmm.
And I, in a bizarre sort of way, I guess maybe this is almost the root origins uh, of the sort of the mountain protocol.
Right.
Is that actually that diagnosis? I become the mountain, as it were.
Oh my
My
Lord.
diagnosis is the mountain, and actually, what I want to do is I want to be just traversing the mountain. So if I can separate myself from my diagnosis, then all of a
Mm-hmm.
sudden, the fear, the anxiety, the worry, all of those things that are so part of your brother's life and my life, as it were, all of a sudden it becomes slightly a little bit, it's a bit more manageable. All of a sudden, this is
Hmm.
just simply terrain that I'm navigating. So this sort of professional and philosophical interest, and then this personal experience of cancer, and that sort of real linking of my identity to it that we
Hmm.
so do. And you're quite right, it feels different in some way. I guess that was the starting point of this protocol, or this idea for me, and
Hmm.
how to work with it differently.
Wow. So the mountain protocol. So help us understand that. So now, what is the mountain again? Is it the disease? Is it the patient? Is it all together? What it for many people, a major problem like cancer does seem insurmountable, like a mountain, right?
For sure, for sure, for sure. I mean, I think, this is where the diagnosis is the mountain, as it were.
Mm.
It simply describes the terrain that we find ourselves upon. Okay, so but the interesting bit is, I guess, I see the diagnosis more as a reference point to where we are on the mountain, if you were to word it that way. So I often, in some of the courses that I run, I ask people uh, a question of what is the most important thing to know if you are lost within a city. And they might give options, or sort of ideas with regards to it. But the most important thing to understand when we are lost in a city is we need to know exactly where we are. We need to
Mhm.
know where our starting point is before we start to move or shift in any sense or form. So for me, all of a sudden, what we're doing is decoupling the individual from the diagnosis. You are not the diagnosis. The diagnosis is just simply a reference point to where you find yourself right this moment. You
Okay.
find yourself
Hmm.
within cardiology team. You might find yourself within an oncology team with a specific diagnosis.
Hmm.
But then, as it were, from that starting point, when we know where we're at, then we start to see our illness a little bit like the terrain. And the mountain in the mountain protocol has three very distinct sides to that mountain. There is a
Mhm.
physical side, there is a chemical side, and there is an emotional or a psychological side to that mountain. And the interesting bit is that obviously, if we have an imbalance or an excess stress on either the physical, the chemical, or the psychological, what we find is we get a dis-ease. The system is knocked out of equilibrium, and we start to have symptoms arising, as it were. So a lot of this about the mountain protocol is just creating an awareness or an understanding as to where we're at, what
Mhm.
the diagnosis means, but also those three interconnected parts between the physical, chemical, and emotional. And for yourself as a cardiologist, I suspect, you see that on a day-to-day basis. If we ask people about their high blood pressure or their arrhythmias or whatever, it is not just a physical cause. There are other contributing factors.
Oh, for sure. And the nice thing about our technology, certainly in cardiology, we can get to a point where we can understand, the relative contributions of this. And when I can give a patient a reassurance that they don't have critical coronary disease, I can tell you a lot of times the chest pain goes away. I mean, we've always said there's a lot of value in negative heart catheterization, completely normal heart catheterization, or nowadays we do CT angiography, because all of us have had some chest pain, all of us, and then in the back of our mind we think, is this the big one? Am I sitting? Am I? Do I have People think that. I mean, you can't help but not think that. All of us will have some of these thoughts come into our head. And you're right. Your opener, you talked about uh, patients, getting better or getting worse. When a patient sees a doctor, and I see patients every day, when they walk into the exam room, I do solicit and get a general self-assessment. Are you better? Are you the same? Are you worse? And so the patient is integrating all of that, right? And then we're getting that read, but it is about the patient. As a doctor, I can't go in the room and say, "How's your left ventricle?"
Mm, mm, mm. So true. I mean, it reminds me. I was just chuckling there because I think one of my favorite little sayings or strap lines, and I must get them printed up as T-shirts because I think I'd make a fortune. But it simply said that there is no problem that we have in this world that our minds cannot make worse.
Oh,
And
that's so
it's the
true.
and it is, I think it captures it so beautifully. Is that the mind is a great modulator. And a patient once wisely said to me, he said that knowledge dispels fear. If we can just start to understand in a very simplistic fashion this sort of interconnected nature of our health, then, like I said, we start to develop this choice, this agency, this understanding,
Mm.
this control, these elements where we are able to shift, as it were.
Yeah,
So,
Chris, I went to one of the best grand rounds I ever went to, was given by an anesthesiologist, and it was about pain. In the United States, a lot of anesthesiologists become experts in managing pain. Some go into that branch actually of anesthesiology. Um, and he said, if you look at chronic pain, he goes, it can be divided into three parts. The first part is there is pain that is pure physical pain. He said, like a knife sticking into your arm. He said, for sure, that's pure physical pain. I mean, that could be a third of things. There really are painful conditions. He said a third of it is just there is some stimulus in the body, but it's an issue of amplification of that signal in the brain. Does the brain perceive that they're taking the same physical signal in one person, they're fine, but another symptom that it's massively amplified, so the volume is turned up. And then he said a third of pain is just completely functional. There's neither one of the first two, and that it really is upstairs, that it's it's truly functional in some way. And it helped me understand that. And I'm sure someone, as a chiropractor, you're kind of in the pain business.
For sure. And it's, the question is, as practitioners, is how is it that we begin to have those conversations with those patients about that? Because, the interesting bit is it's that very nerve-wracking moment where you start to, you start to explain that logical third, and there's that awful moment where patient turns around to you and just simply says, "What are you doing? Are you telling me it's all in my head?" And you're like, "Oh, no." You start to backpedal, and I guess the way of describing it in this sort of interconnected model, is nothing new. That sort of triad of health, physical, chemical, and emotional. Psychological stress in our life will manifest in both chemical changes. There's obviously increased levels of cortisol and increased levels of inflammation subsequently in the body. We also obviously will see it physically manifest. We will all feel tense in the jaw, tight in the shoulders. We'll all have so by unpicking it and normalizing it and saying we all feel this, the hope is that it becomes a slightly more open and more receptive person, or receptive, a better way of explaining to an individual or to a patient without them shutting down and closing down to us.
Well, let me ask you. So, can stress alone, let's say, emotional stress, financial stress, family, relational stress, can that manifest as pain?
100%, without a doubt.
Yeah.
I think I would also go one step further and say it will also manifest as illness. And I've got plenty of sort of professional evidence, but I'd say that the most powerful for me would be a personal evidence of that. So my cancer diagnosis, what preceded that was a protracted period of chronic stress, very powerful emotional problems within my family, within my wider family, which manifested in me fracturing both of my heels quite catastrophically. And the interesting bit is that chronic personal, psychological, and emotional challenges manifested in me fracturing my heels. But my cancer diagnosis was almost 1 year to the day after my fracturing of my heels. And I am 99.9% certain that both the psychological, the physical manifested and pushed the system towards this dis-ease that manifested as my cancer, without a doubt.
Well, it's so interesting that more and more, and actually, cancer, more and more therapies are oriented towards this interface that we probably are forming cancer cells in our body all the time. And then we have an immune surveillance system that identifies the cancers and knocks them out or contains them in some way. And that there's a balance. And when the immune system is down, the cancer immune system or cancer surveillance system is down, then the cancers advance or can be expressed. And it's been said, let's say for neck cancer, from the time the very first cancer cell was there, Chris, to the time it was recognized was probably 5 years.
There we go. How
Yeah.
interesting. How interesting. And so this sort of this space, this opening, this like weakness in the system, as it were, where these things show their face, as it were. This is, I guess, again, to help patients, maybe like myself, that sit on this sort of mountain, this diagnosis of cancer, all of a sudden to understand this sort of the interconnected nature of health. And literally, it's just that constant questioning of, where are you right now? What is the biggest stress in your life? Is it a physical stress? Are you excessively drinking? Are you not taking care of
Mm.
yourself? Are you,
Mhm.
or is it, are there psychological stresses? Have you lost your job? Or is it something else? So by simply just understanding or exploring the terrain that we sit on in this way, what we then develop is this space this space that comes from understanding, but then it moves on into choice, agency. But also
Hey,
then it
Chris,
becomes,
Chris, before you leave stress, I wanted to point out, have you heard the term sandwich generation?
oh no, come on, I
Yeah.
haven't heard that
So
before.
I think you and I are in the sandwich generation. So the sandwich generation means that we had a source of stress as we raised our children, and some of us still have stress if children have gone astray or they themselves are facing difficult. As a parent, you are responsible for your children. You're forever responsible for your children. But also, we become responsible for our parents and our senior citizens, our elderly. So we're in the sandwich. My wife and I just talked about this today. I said, we have been, daily actively consumed by senior management of our parents and in helping them in every way we can, at least for 6 years, and for some, this can be a decade or even more. So we're called the sandwich generation. And so when we review our parents, so for instance, my mother and father had no responsibility for their parents. Sadly, they died early. So they didn't
Mm,
have a prolonged period of time where they're worrying about care. And, my wife is going to be racing to the store today to try to get something for my mother who's out of the hospital, but my brother stayed with her last night. There's all these things, and I'm juggling my schedule. Um, my parents never went through that because sadly people died earlier. But now in this new sandwich generation, people, are living longer to the point where they have, there is certainly a rising fraction of seniors with Alzheimer's disease or other forms of dementia living longer, stroke, physical disabilities,
mm,
and so the responsibility is in the middle. And I do sense this a lot. I had patients yesterday who said, "Listen, I had 20 years of chronic stress, and it was family stress because I was responsible for this situation." And it's great when all the family members are a great team, but many will admit that families aren't a natural team, and a
mm.
lot of times if things will fall on one person or another, and there's contentious discussions. But Chris, we're going to take a break here, and we're going to pick up on the back side of this, and we're talking to Dr. Chris Robillard, who's from the UK. He looks terrific because he's in the wonderful resort community of Bali. You can't see it, but he's got his swimming trunks on underneath. He's going to go surfing after we get off. And we've been talking about the mountain protocol, this whole issue of when a disease becomes so big as a mountain, and where is the patient? Is the patient the disease, or do they, where is their identity, their agency? And so you're listening to the McCullough Report. Let's get real. Let's get loud. On America Out Loud Talk News. This is McCullough Report and Focal Point Substack. Let's pause right here. Let's get real. Let's get loud on America Out Loud Talk News. This is McCullough Report and Focal Point Substack. I'm Dr. Peter McCullough, your host. Our guest today is Dr. Chris Robillard, who is a man of so many, talents and so many different facets. He's a chiropractor. He's a psychologist, and he's someone who's very thoughtful and I think very careful in his deliberations. And he's been a patient himself, and we've been talking about the mountain protocol. So, Chris, why don't you pick up on where you were about the patient and this whole, how we navigate. So there's a mountain, but on the mountain there's terrain, right?
And the terrain is just simply, like I said, that physical, that chemical, that emotional sides to it. So by understanding and orientating ourselves with our diagnosis, and then understanding the shape of the mountain, the steepness, what is causing me challenges, all of a sudden, like I said, that sort of decentering, that separating ourselves from our diagnosis, that can in itself be quite liberating. It's that idea of metacognition. It's observing our illness rather than being part of the illness itself. But the interesting bit is that modern medicine, we also tend to sort of pathologize the distress that comes along with the illnesses as well. So the depression, we medicate. I had it with my cancer. Is, oh my goodness me, you're having problems sleeping as a result of your diagnosis. Well,
Ooh.
yes, you've just diagnosed me with cancer. Here's a sleeping tablet to help you sleep. Well, I'm really quite depressed with it because of the fear and the worry. Here you go. This is something to be eradicated. My anxiety, again, here's something to eradicate it. And within the mountain protocol, the way I introduce it is that this sort of distress they're simply like storms on the mountain.
Hmm.
They come and they go, but they're not dysfunction in the system. Distress is basically information. It lets us know how the system is reacting to whatever it is that we are experiencing. And so as we explore, and what we simply do is we ask the clients that we're working with is, well, what are the storms for you right now?
Mhm.
What's going
Mhm.
on? And, for yourself at the minute, if I asked you, there's quite a lot of storms going on. There's worry and fear, and with regards to your mum,
Right.
they're the storms. But the interesting bit is if we don't pathologize it and we talk about it as being normal, this is normal
Mhm.
reaction or response to a challenging situation. The invitation then is to ask people, well, what is it that creates steadiness for you? What creates an element of just being grounded? Are there areas where you can shelter, do you think? What is it that creates shelter? So all of a sudden, what we start to do is we know that storms pass. We know
Mhm.
that there's a calm point in the eye of the storm. We know if we can just find that. But we also know that if we can just find something to either cover us, shelter, hunker down, or somebody to help us, then we can allow that storm to pass through, as it were. So distress is not dysfunction. Distress is information. It's just a storm on this mountain, as it were.
Yeah,
But
I
then,
think it's a terrific analogy or kind of imagery here. And one of the things I try to do is in this type of circumstance is to ask people about success. So ask them, what works well for you? What is working well for you? But most of the time, the questions are in the negative. Well, what can't you do? What are the problems? What have you? But to ask people, what works well for them?
mm, and it's so powerful. I mean, what works well for you, all of a sudden you can probably just feel, you can feel your feet just steady and everything just, and the
Oh,
interesting bit is, it's
yeah.
just that sense of what you're doing by saying that, Peter, is you're trusting them and you're validating whatever it is that they find that steadies them, and that is such a powerful tool.
Well, positive is so much stronger than negative. And in healthcare, that interaction is critical. In the medical specialties, cardiology is really kind of the top of the totem pole. People say, listen, without my heart, I'm a goner. So the cardiologist is kind of at the top. And so I've noticed, and I did work as an internal medicine physician for years before I trained in cardiology. So I recognize that stair step up, that when you're in the office with the cardiologist, there is a lot of acuity. There's people taking notes. There's oftentimes family members. Sometimes they say, can I record everything? I want to make sure I understand every word. And I imagine it's similar with cancer and oncology. I think they're right up there. And so when you visit with your cancer team, there's so much going on. I can't imagine as a patient, how tense and anxious those appointments must have been.
They are, and I mean, it sort of moves into the next part in the respect that those appointments, what you end up finding is that there is a real asymmetry in the system, as it were. And what I mean by that is that you are something that this is done to. There's a power asymmetry. There's the specialist, there's a doctor, and then there's yourself as the patient, as it were. And what it does is it almost creates this sort of passivity as a patient. You're just somebody that's receiving their expertise, as it were. If you venture up at points, which I did, venture up a possibility of, I want to do something different. I would like to explore this. I'm deemed as a heretic in some way, going, one question that highlights it for me was, I didn't want to know what staging my cancer was. For me, wasn't important. I was either going to live or I was going to die. But if there's something different to them telling me it's stage 1, 2, 3, or 4. So I'm in a multidisciplinary meeting, and I was simply asking. They said, "Well, we're going to, after your surgery, we're also going to give you chemo and radiotherapy, and then you're also going to have 6 sessions of chemotherapy." And I said, "Well, sorry, nobody told me I was going to have chemotherapy." I said, "Can you tell me, where's this all of a sudden come from?" And somebody at the back of the room who I never saw just shouted out, "Well, if I had stage 4 throat cancer like this, I would have everything." And for me, it just highlighted this asymmetry in the power, as it were, or within the interaction itself, which was quite troubling and destabilizing at points. And the protocol, again, with this understanding of terrain, with this understanding of the storms, with this understanding of the fundamental basis of where I find myself, then with that awareness starts to become a choice. Then I start to be able to see the elements where I might be able to, and a sense of agency. I can follow this. But this has also got to be respected by the practitioners, by the medics as well. And I'm hoping the intention with this is that it becomes a blueprint upon which both medics and patients alike can understand where the roles begin and where it ends, and where the patient's desires and wishes begin and end as well. Does that make sense?
A lot of that has to do with this idea of having agency and actually having some choice in things. A lot of that has to do with kind of the layout or the blueprint of the information. So let's take cancer, for instance. And I've just had a patient go through this, where she has had a surgery. The surgery has removed the cancer. Now the issue is, could there be any other cancer cells that we don't know about, that are not in the lymph nodes? We check those. And should we give chemotherapy just for that extra measure? And that's the difficult thing, because then the question is, well, doctor, what's the chances there's a cancer cell somewhere else? And that if I decline chemotherapy, that, I could be making a tremendous mistake. And there, were you in that situation where the cancer was gone and the surgery and radiation had done the job, and now you're in this probabilistic web where you're trying to figure out, should I take chemo to kind of cover that possibility? Was that the situation?
100%, yes. So the reason I sort of chuckle is that there was this moment where I'd had so they told me that I was going to have 4 rounds of chemotherapy, so good old chemo radiation, and the ravages that that creates. So I came to the end of my fourth session of chemotherapy,
Uh-huh.
and and my bloods were quite good, and I was doing
Mhm.
okay. And I met the oncologist, and he said, "Well, look, I'm really pleased to say that your bloods are great. So we're going to book you in for another 2 rounds of chemotherapy."
Bonus rounds.
And I said, can I just pause you there? I said, first and foremost, I didn't know I was having chemotherapy to begin with. And now you said 4, and then now you're springing another 2. I said, can you give me a clear-cut rationale as to why I should have 2 more sessions? Can you give me, outcome measures, etc.? And he
And he,
and he and honestly, and he was a lovely man, I hasten to add, but he just said, no, I can't. He said, it's just protocol. And that was it. And so I said, well, do you know what? You can leave those 2. I've had enough, thank you. And I sort of
well,
didn't
Chris,
take those
don't
last
you
2.
don't you think that's a tough part of cancer? I think cancer is different than a lot of other areas of medicine, where the word protocol is used. And people are saying, well, you get surgery, you get chemo, and you get radiation, and it's protocol. I mean, and anybody, I really want the listeners' feedback on this. If you've had cancer or someone in your family's had cancer, have you been faced with that it's protocol? Because I can tell you, in cardiology, we don't have that so much. There's a lot more stylistic ways. It's not like when I see a patient with heart failure, it's protocol that you do this. It's just, no, it's an integration of things. And I think that's the problem with cancer, and how cancer evolved was all these layers of randomized trials and one drug on top of another and one protocol. And it's this incremental advancement. And patients in these cancer centers in Texas, we actually have the MD Anderson Cancer Research Center in Houston. And, I refer patients there, but they tell me, listen, when you go in there, in a sense, the entire institution is a giant protocol, and you just are right in there. So, Chris, we just have 2 minutes left. Tell us where we are with this and your advancements. How do people learn more about the Mountain Protocol, and in particular your work with clients?
So obviously I work one-to-one with people mainly online at the present time, and it's those that are obviously navigating complex illness and chronic health. So especially those that have been through cancer protocols and treatments and coming out the other side. And although they may well be, as it were, cured, they may well be like myself 10 years down the line. There's
Wow.
still a process of healing that's required, and it's that group of people or clientele that I'm most certainly interested in helping explore and navigate their mountain, and hopefully create this collaboration, this choice, and this movement towards their own goal, as it were. So, that's my hope. They can find me if you go to www.themountainprotocol.com.
Oh, that's great.
That's
Hmm.
my website,
Hmm.
and maybe you can put a link. I can put a link onto your site as well, and they can
Well,
find me there.
well, Chris, I get contacted daily from people all over the world in these types of predicaments, and I'm gonna send them to you. So if they go to the website, can they enter their information and then you'll respond, or your
Yeah.
team will respond?
Yeah, contact me, and I'm always up for a chat. Yeah, I love to talk. Look, this is something that I'm most passionate about. I see it of great benefit, most certainly to patients. I also see it of great benefit to clinicians as well, because
Hmm.
what it's my hope is that it also takes a lot of the burden and responsibility off. Clinicians, because what it will do quite clearly is define, like I said, roles and responsibilities, and yeah, where help begins and ends, as it were. So, I really do see this of benefit to most certainly to patients and clinicians alike. So, but yeah, thank you ever so much for having me today, Peter.
Been a great discussion. I was so honored to meet you in the UK in Guernsey, and great to see you're in terrific shape. Now, Chris, is the final word here? You're more than 10 years after stage 4 throat cancer?
I am indeed. Yeah, yeah,
Gosh, that's
most
so
certainly.
amazing. Your
So,
voice is just a little gravelly, just a little, but not much, not
I know,
much.
quite
So,
quite sexy.
but there you go. Yeah, you're right. Well, listen, this has been a terrific interview. We've been talking to Dr. Chris Robillard, who is a chiropractor, a psychologist, someone who's a cancer survivor. And go to the Mountain Protocol, www.mountainprotocol.com. That's how you can reach him. And we've learned so much. Chris, I got to have you on again. Terrific interview. Thank you.
Thank you ever so much for your time, Peter. And yeah, I hope your mum does well. So listen, sending much love.
Thank you.
Take care. Good night.